Okay, so welcome to the first Physios for ME podcast. We are a group of physiotherapists with a special interest in ME, and you can read a bit more about our aims and ambitions on our website, which is physios4me.com. To introduce ourselves to you, you've got the whole Physios for ME team here. My name is Karen Leslie. I am a physio specialist in neurology. We've got Dr. Michelle Bull.
Hi, I'm a transformation program manager at the moment. That's a non-clinical role, but my clinical experience has been in cardiac rehab, cancer rehab, and physical activity promotion.
Okay. And we have Dr. Nicola Clegg-Baker.
Hi, I'm the associate professor, one of the associate professors, University of Leicester Physio Department, and my main speciality is neurological physiotherapy, but I also do treat people with neurological problems as well.
And we have Natalie Hilliard.
Yes, I'm a physio, currently working in private practice in the community.
And we are delighted to be joined by Dr. Charles Shepherd. Thank you for joining us today, Charles.
Well, thank you for inviting me. So I'm Charles Shepherd. I'm medical advisor at the ME Association, where I've been doing this for about 25 years and dealing with people who have post-viral fatigue syndromes, and then going on to develop ME/CFS. And I also have personal experience of this illness, ME/CFS, and post-viral fatigue syndrome, which is how I got into this subject, which I developed this condition following a very nasty dose of chickenpox, which I caught from one of my hospital patients many years ago.
Okay, thank you. So the subject of today's podcast is tagged on to the things we've been doing about COVID-19, and it's designed for physios and any other allied health professionals working with people post-COVID in that kind of rehab setting. And we want to talk about post-viral fatigue syndrome, but obviously our experience is mainly around people with ME. But we think that we can kind of apply that out to any of the patients that our colleagues might be dealing with out in the public. So Michelle, could you start by talking a little bit about post-viral fatigue syndrome? And I know you've got a specific experience about that yourself.
Sure, thanks, Karen. And I think it's really important to stress that one of the things I'm hearing a lot from my colleagues is around the whole COVID being a new disease and how we're having to extrapolate our knowledge and our learning from other conditions to help us sort of navigate our way through with what we do with it. So I thought it would be useful just to talk a little bit about my experience. So a few years ago, my son spent a week at sports camp and then became really ill with a viral infection. He was in bed for about 2 or 3 weeks and he was fairly debilitated afterwards. And so I started to work with him to increase his activity levels using the quota contingent approach that I think as physios, most of us use on a regular basis, going out for a walk every day and gradually looking to increase either the duration or the intensity to keep improving function. However, every time we tried to increase it, we got an increase in his viral symptoms, got extreme fatigue, often putting him back in bed for several days. And even if we just tried to get him in to do one lesson a week at school, that made his symptoms flare up so bad that he was back in bed for another week. So for me as a physio, that certainly wasn't what I was hoping to achieve. And it really wasn't the sort of traditional response to rehab that I was expecting. So I sort of stopped and looked back on the sort of critical thinking core physio skills, you know, treat, assess, review, and said, okay, something different is going on here. So what could be happening? Did some more research, found out about post-viral fatigue syndrome and about ME, which was an exact fit. So what were those sort of indications of post-viral fatigue syndrome that my son was exhibiting, and what might people want to look out for? So it is that intermittent and recurrent flare of the viral symptoms, activity-induced fatigue, and that's both from mental and physical activity. Unrefreshing sleep was a big thing. Even though my son slept for ages, he'd wake up and still be really tired. Cognitive problems, unable to get back to his previous levels of activity, and also orthostatic intolerances. So quite a big big mix of symptoms there, and you can see more about those on our website because I've rattled through them quite quickly. So I had to sort of change what I was doing with my son and say, right, what do I do now? And the sort of key management techniques that physios and other AHPs might find useful: rest before getting tired and don't push through, prioritize sleep and nutrition, and take a symptom contingent approach to activity management. So trying to avoid that symptom flare and conserve energy. So that's for both mental and physical activity. So don't read for hours, as well as don't go for really long walks. Break up activities into smaller chunks with rest in between. One of the things we found really useful was using a diary to help us remember what might have caused a flare, because symptom flare can often be delayed by about 48 hours. And teenagers aren't great at remembering what went on a couple of days before. And then also about adjusting based on your symptoms. So don't stick to the same amount of activity as the previous day. If you are having a symptom flare, dial it back a bit. And we found actually by using these techniques that we've seen slow but steady improvement in function without the big symptom flares. So we've managed to avoid the boom and bust that we were getting when we first started. I realised that that's quite a different approach to the traditional reconditioning approach that we as physios are used to using. But I would just say, if you aren't getting the response you'd expect from a traditional rehab approach, then stop and think about post-viral fatigue syndrome and perhaps adjust your management strategies accordingly.
Mm-hmm. Great, thanks Michelle, and thanks for sharing your story about your son as well. Charles, could you, with your medical hat, could you talk to us a little bit more about kind of what you expect post-virus, what post-viral fatigue syndrome is, and how that might link to ME?
Yes, I think it'd probably be helpful because we're talking now about, in relation to COVID, we're talking about post-COVID fatigue, post-COVID fatigue syndrome, and whether this might develop into ME/CFS. So if I just quickly start off by just really summarising what we would regard in normal medical practice as post-viral fatigue syndrome, and how that might link into ME/CFS. So to start with post-viral fatigue, I mean, having worked in both hospital medicine and general practice, I'm very aware, and certainly all general practitioners are aware, that post-viral fatigue, some of them call it post-viral debility, is extremely common after viral infections, a whole range of viral infections. So primary care is very used to seeing this. It normally resolves in a matter of perhaps a few weeks at most. It's normally a self-limiting thing, and providing people just act sensibly, it goes away. And I think probably most people have experienced some degree of post-viral fatigue. When that doesn't really go away, and we're talking perhaps about a post-viral fatigue which is going into, you know, a month onwards from symptoms, and there are other symptoms as well. You're continuing to feel virally, you may have sleep disturbance, you may have a bit of cognitive dysfunction as well. So you've got the fatigue plus the other symptoms, plus it's really having some significant effect on your normal life, whether it's your work, your education, whether you're trying to run a home, your social life, you can't get on with that. Then I think fatigue plus the symptom complex, you need to be thinking about, is this a post-viral fatigue syndrome? And again, if that is managed sensibly, in most cases that resolves itself. But there are a small minority of people who then go on, these symptoms of post-viral fatigue syndrome persist, and certainly from the medical point of view, I think it's generally agreed that when you've got these sort of symptoms, really debilitating fatigue, and especially when you've got this sort of ME/CFS type symptom complex occurring in conjunction with that, then you should be really querying whether this patient is going on to develop ME/CFS or has actually got ME/CFS. And the timeline that we use, certainly in the NICE guideline and also in the Chief Medical Officer's report on ME/CFS, which I helped to write, we're normally saying that in children this should be a 3-month time span, and in adults 4 months. So you should certainly be considering this diagnosis if it's going on for several months and actually making the diagnosis. And of course, in relation to ME/CFS, I think there are 5 cardinal symptoms that most people generally agree on. Michelle's already mentioned, I think, most of them, but if I just reiterate, we're talking about activity-induced muscle fatigue, often with muscle pain. We're talking about cognitive dysfunction, problems with short-term working memory, attention span, information processing, orthostatic intolerance, and other autonomic nervous system dysfunction symptoms may include postural orthostatic tachycardia syndrome in adolescents. The sleep disturbance part is very important in this. It's unrefreshing sleep, and often in the very early post-viral stage, it's hypersomnia. It's people wanting to sleep 12, 14 hours a time. As time goes on, that can be more disturbed. And then you put all those together and you have this very characteristic diagnostic feature of ME/CFS, which is the post-exertional malaise, whereby you do too much on one day when you're feeling good, then you feel lousy the next day and you have a symptom exacerbation. And that's why many of these people will describe a sort of very up and down, boom and bust type pattern. Just briefly how that all translates into the COVID situation. I have to say, most of the people that we are hearing from at the moment are not the severely affected people who've been in ITU with severe cardiopulmonary complications and are then coming out. The people that we're hearing from, and I'm personally hearing from as well, are people who've been self-managed at home who are coming back, and they are just grossly fatigued after this illness, which I think is hardly surprising because fatigue is a big component of COVID in the actual infective stage. But it also seems to involve this cytokine surge in some people. So, and we know in ME that cytokines, immune system chemicals, seem to be playing a part in the ongoing production of this illness. So there are a number of reasons why that may be occurring, but COVID is clearly a complex multi-system disease, and particularly from the point of view of the respiratory complications. So some of these people are reporting fatigue, which seems to be very much akin to the normal post-viral fatigue that we're used to seeing. But if they've got or if they've had any sort of pulmonary symptoms and they've still got some pulmonary symptoms, they're a bit breathless, or they've got palpitations suggesting there may be some cardiac involvement, then of course that could be, causing fatigue as well. And it's not always easy to disentangle these two. And then we've got others who are coming along with the history of COVID, the fatigue, sometimes the other symptoms which are characteristic of ME, but they've also got the respiratory, perhaps lingering respiratory symptoms as well. So they seem to have a post-COVID fatigue syndrome, which is rather like ME, but a bit of COVID illness tagged onto it. And of course, as we're now entering, 3 months plus into this pandemic, I'm also making a provisional diagnosis of ME/CFS in some of these people where the ME/CFS symptoms seem to be quite predominant. The fatigue is there. And I think, as was interesting, was discussed at an RSM webinar earlier in the week with some pulmonary physicians. I think a lot of us are expecting to see quite a lot of people with ME/CFS as a result of this illness.
Wow. Thanks so much, Charles. That's really interesting. And I think we, as Physios for ME, we've had a few people contact us with post-viral fatigue symptoms. And similar to yourself, a lot of those have been on the self-care at home spectrum as opposed to being hospital inpatients. So there's probably a big cohort out there, isn't there? Of
I mean, it's interesting that I can't recall at the moment any. I mean, these people are going off elsewhere. I think the people who are coming out of hospital, they are very unwell still, and they're going to need an awful lot of rehabilitation and care. But these are not the people that are coming to us at the moment. It's very much the home managed people.
Yeah. Nikki, would you, I know Charles and Michelle now have both mentioned post-exertional malaise as one of the main symptoms. And I know you've looked a lot at the physiological side of that and sort of with a physio head on and exercise physiology. Can you explain a little bit more about what's been happening in the background of post-exertional malaise?
Yeah, well, there's been a significant amount of research over the last 20 years, really, in relation to exercise physiology and ME. Obviously, we don't know if these are the physiological changes that are happening with people post-COVID, but there are lots of similar signs and symptoms, so there might be some similar difficulties happening with their exercise physiology. So we can report on the ME research and as you say, extrapolate potentially. So in 2019, a research group in the US led by a physical therapist called Todd Davenport published a systematic review of 36 studies, including over 2,000 people with ME who took part in maximal cardiopulmonary exercise tests, or CPET tests. Most of the studies were in the US, and the significant conclusion of this systematic review was that there was abnormally blunted heart rate responses at maximal and submaximal exertion, and this is called chronotropic intolerance. Charles has also alluded to other cardiovascular abnormalities in people with MEs. They do have reduced cardiac output, insufficient blood pressure on exertion, and some people have the orthostatic intolerances such as postural tachycardia syndrome, or POTS, which is an increase of 30 beats per minute on standing. And some of them will have neurally mediated hypotension, or NMH, which is a greater than 25 millimeters drop on standing. And the cause of these abnormalities is unclear, but one hypothesis is that there are some abnormal autonomic nervous system changes. Another theory that I've read recently was a beta-2 adrenergic receptor problem in the blood vessels, which lead to abnormal problems with lack of dilatation or dilation of the blood vessels. So our advice to physios treating people with COVID-19 who might be showing signs of post-viral fatigue syndrome is to measure their heart rate and blood pressure before and during doing activities and exercise. Now, most physios do that anyway, and most will be checking their pulse oximetry as well during exercise to check for particularly silent hypoxia, which seems to be a major problem post-COVID. But if they see any signs of CI or POTS or NMH, then there are a number of websites that we can point them to, and we suggest that you go to either the ME Association website or the Physio for ME website, www.physiosforme.com, and we can signpost you to various websites to help with these symptoms. Certainly people with ME use heart rate monitors to check their heart rate variability, because this is a sign of the or a measure of the autonomic nervous system, and to see whether the sympathetic or parasympathetic systems are being too dominant. So these CPET tests have also shown that people with ME have abnormal metabolic responses to exercise. So these include a reduced maximum oxygen consumption and a reduced anaerobic threshold. So just a reminder that maximum oxygen consumption is the amount of oxygen that people can consume doing maximum exertion, and it's measured in milliliters of oxygen per kilogram per minute. So that's reduced, and also the anaerobic threshold, where somebody will switch from aerobic metabolism into anaerobic metabolism, and this is also called the lactate threshold. So we're having problems potentially using aerobic metabolism and switching too soon into anaerobic metabolism. And again, it could be due to autonomic nervous system changes. It could also, there's some evidence that the red blood cells have got changes that will affect the transportation of the oxygen, and there's some evidence for mitochondrial changes as well. So this switch from aerobic to anaerobic metabolism in the actual mitochondria cells. As a result of this early switch, there is some evidence to show that there is intracellular acidosis in exercising muscles and a poor recovery from this acidosis. So this potentially could explain some of the symptoms of the primary feature, which we've mentioned, the post-exertional malaise, or MEP-PEM. So we've said it already, but acute flu-like symptoms, headache, dizziness, sensitivities to light, to sound, pain, particularly muscle pain, fatigue, and reduced cognitive function or brain fog. And this post-exertional malaise can be delayed up to 24 to 48 hours and can last sometimes weeks and even longer. And some of the studies on using CPET tests have been 2-day studies. So they do a CPET test one day and then 24 hours they do it again. And they've seen a significant drop in the VO2 peak on the second day for people with ME compared to healthy individuals, potentially reflecting this post-exertional malaise. People with ME tend to use heart rate monitoring to keep underneath their anaerobic threshold to potentially reduce that acidosis and reduce their post-exertional malaise. So our advice for physios working with people with COVID-19 would be to watch out for these delayed responses to exertion, whether it's physical or mental exertion that can trigger their post-exertional malaise. And if you see signs of this, then possibly your patient is developing ME. And people with ME have stated that they wish in this early stage they were told to rest, sleep, avoid symptoms, eat and drink, and use symptom contingent pacing. And we know that people with severe and very severe ME have also said that pushing exercise at this stage actually pushed them into severe ME.
Thanks, Nikki. That's really interesting. And so I guess we're saying then, due to either physical or cognitive exertion, we're getting these like detrimental cardiorespiratory changes. And you mentioned then severe and very severe ME, and I think that's the side a lot of physios and HPs might not even be aware of, potentially, if they've never come across it. Natalie, you were going to talk a bit about severe ME from your experiences, weren't you?
Yeah, thanks, Karen. So, yeah, my understanding of ME was really very limited until I met my friend about 4 years ago, and she fluctuates between severe and very severe ME, which basically means when she's good, she's mostly bedbound and requires a lot of care, especially food preparation, housework, admin stuff, and some personal care. Like we've kind of all said, symptoms, classic symptoms of pain, migraine, flu-like symptoms, feeling generally unwell, and a sensitivity to light and sound, fatigue, weakness, and of course the orthostatic issues. When she's in a severe relapse of her ME, she's 100% bedbound, needs 24/7 care, feeding, drinking, toileting, turning, hoisting, is extremely unwell. And all the body systems just shut down. And the only way I can describe it is like a plug that's just been pulled out of the socket. So what's relevant to this podcast is how she developed ME over 20 years ago. So she and a colleague at work both developed a severe flu-like virus. She recalls feeling very unwell, sweaty, shaky, had a rash, and visual impairment. She remembered having to leave work early on that day. And then the following day, she woke again with all these flu symptoms and was really swollen. And then a few days later, she developed breathing difficulties and was taken to hospital. And during an admission there, she was diagnosed with adult onset asthma. And so to this day, her asthma isn't typical presentation. It's when her ME symptoms have flared, her asthma is worse, and vice versa. So it's like a viral asthma, which seems to flare up when she's struggling. Anyway, 6 months on from the initial onset of her illness, she's not recovered, still had the breathing difficulties and these viral symptoms. She was completely bedbound, needing full personal care. Her previous life, which was full, including running a charity, was now non-existent. She was unable to function with any normality at all. At this point, she was diagnosed with a post-viral fatigue syndrome. And 3 months later, when still the symptoms were present, she was diagnosed with ME. She never recovered. Even now, 20 years on, as her carer and as a physio, it can almost seem like the virus is still in her. And I know Charles mentioned cytokines, so that makes sense. It flares up even when she exerts herself a little too much, and that can mean talking for longer than 10 minutes or just taking a shower. The exacerbations of symptoms, as we've discussed are the hallmark feature of ME, which is post-exertional malaise. We still don't fully understand the pathophysiology of the post-viral ME, but as we've mentioned, it's a complex multi-system illness with a clear viral onset. In the early days, my friend was treated really well by healthcare professionals because they could see the clear cause of the illness, they saw it. Since her diagnosis of ME, she's experienced quite horrendous abuse by healthcare professionals, as ME does have the stigma of being psychosomatic. She was told to push through, sent on an inpatient rehab program where she lasted 1 day, and it took her into a really severe relapse. My friend also says to me she wishes health professionals told her to rest within the first few years of illness, and to really, really rest. She believes the outcome would have been different. And this echoes what many other people with ME say. As a physio caring for someone who is this sick, I would urge all my physio colleagues to be alert when it comes to post-viral fatigue or any post-viral symptoms, such as cardiac issues or neurological issues, because it's clear that the patient's body is struggling. Be cautious, encourage your patient to rest, to pace their activity and to monitor their symptoms carefully. Any exacerbation of symptoms might mean they're doing too much. And this could then increase their chances of developing ME, whether that be a mild illness or a more severe illness. I would also say that patients in this situation will probably be really keen to get well and be very highly motivated and may then do more than they can. And I think our job is to go really slowly. My friend also wishes she was offered a community physiotherapy in the early days, because even travelling to an outpatient clinic would exacerbate her already severe symptoms. Please bear this in mind if you come across a patient who's not responding in the expected way. And sadly, we know with severe and very severe ME in adults, there's not a good prognosis. So really, prevention is better than cure.
And thank you to your friend for letting us share their story as well. I definitely think with these kind of post-COVID patients, for physios, there's going to be that temptation to see them as simply deconditioned. And in many cases, that probably is going to be true, and they'll respond as you'd expect to with our treatment. But when someone isn't progressing as much as you predict, when they're showing these symptoms we've been talking about, these recurrent flares, this unrefreshing sleep, they're just not getting back to that baseline. I think that's when we need to take that step back, isn't it, and really evaluate what be going on. Consider this possibility of post-viral fatigue syndrome or even ME, and change your approach. And I think if you're not sure, then I think we'd all probably say maybe be cautious. The worst that's going to happen is someone might have rested for a little bit longer than they needed to. But if you go the other way and push through, as we've seen, the potential for damage is pretty severe. I think we're the four of us are physios, and our primary driver is always to make someone better as a profession, to improve their quality of life. And we have these go-to treatments that are evidence-based and they work for most of our people we work with. And if they don't work, there's that temptation to kind of pin that issue on somebody else and blame somebody else. And as physios for ME, we get a lot of stories from people with ME in our inbox and through social media about the historic treatment of ME by our profession. Patients have told us they've been labelled as uncooperative, unmotivated, they've been discharged from services because they couldn't manage the programme they've been given. And it's created a really poor perception of our profession within this patient group. Last year, with the help of the ME Association, we did a survey, didn't we, of it was over 200 people with ME, and asked their opinions on their experiences of physios. And 54% said they had a negative experience. And more worryingly, 53% said their symptoms got worse after physio. So I don't think, and we don't think that historically we've been getting this right as a profession. The good news is, though, we do get positive stories, and these aren't necessarily about physios that are ME specialists. They're just about physios that are willing to learn. They can spend some time listening to the patient, they can adapt their treatment, try new approaches, basically being able to acknowledge a patient's problem and believe them and not dismiss them I think that goes a long way really for the patient's experience. But this pandemic, I think, is our profession's opportunity to maybe change the narrative a little bit with this new cohort of patients coming through that, as Charles mentioned, there may well be a rise in ME patients. And as we don't know all the answers, particularly with COVID, but still with ME, there's a lot of unanswered questions. We do still think that our profession has got that skill set that can have a positive impact on someone's life. We just need to approach it with the right level of caution, with an open mind, and perhaps with a bit more knowledge, and basically make sure that our treatment is individualised and, you know, constantly monitoring and evaluating, as I think we've all been saying. So as Physios for ME, we're regularly updating our website, we're signposting resources, and we welcome professionals to get in touch with us so we can carry on building up a big kind of knowledge base of what's happening out there with this patient population. And hopefully if we can keep sharing that information, then we can all kind of progress and achieve something together. So yeah, that was our first ever podcast, and hopefully we'll do more. Thank you so much, Charles, for joining us. That's been really helpful. And perhaps we'll see you at another one in the future.
Thank you. I will.
Thank you. Yeah, thank you very much.
Yeah, thank you, Charles.
And thank you to Physios for ME team. And we'll see you again soon.